Welcome to Harrison-based Clinical Pearls in Medicine. Today's topic, evaluating acute mental status changes in the ICU. An 82-year-old woman was admitted with severe sepsis from pneumonia, complicated by renal and respiratory failure. She's been on mechanical ventilation, vasopressors, broad-spectrum antibiotics, and chemical sedation. Initially, she was calm and alert, but now she's agitated, awake all night, and unable to follow simple commands. Which of the following tests is the next most appropriate step in evaluating her new symptoms? A. Brain MRI with and without contrast. B. Head CT without contrast. C. Rapid plasma reagent. D. Serum chemistries. E. Urine toxicology. What's the most common cause of acute confusion in a critically ill patient? And how do we look for it? The correct answer is D. Serum chemistries. In critically ill ICU patients, the most common cause of acute mental status change is metabolic encephalopathy, not structural brain disease. This can result from electrolyte abnormalities, renal or hepatic dysfunction, hypoxia, sepsis-associated encephalopathy, or medication toxicity, especially sedatives like benzodiazepines or opioids. The first step is to evaluate reversible metabolic causes, starting with serum chemistries, electrolytes, glucose, renal, and hepatic function tests. Brain imaging, such as CT or MRI, is indicated only when focal neurological signs, trauma, or seizure activity are suspected, none of which are present here. RPR and urine toxicology are inappropriate in this acute ICU context. Always remember, in an ICU patient with new onset confusion, check the chemistry before the CT. Metabolic causes are far more common and often reversible. Common culprits include uremia, hyponatremia, hypoxia, hypercapnia, sepsis-associated encephalopathy, and drug toxicity from sedatives or analgesics. That's your Harrison-based clinical pearl. In ICU delirium, think metabolic first, imaging later. Always correct what's reversible before chasing rare causes. Stay tuned for more high-yield, bedside-oriented insights here on Harrison-based Clinical Pearls in Medicine.